Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today, I'm delighted to be joined by Ryan Howells. He's a principal at Leavitt Partners, but also the program manager for the Karen Alliance and part of the vaccination credentialing initiative for verifiable health data. Ryan, thanks for joining me today.
Thanks for having me, Nick.
So help the listeners understand a little bit about you, your background, how you came to this role, and some of your history that's sort of relevant to all of this.
Sure, happy to, Nick. So my background is all really in healthcare technology, worked for consulting companies, worked for startups, vendors, organizations, health plans, and others, and came to Leavitt Partners about 5 years ago, where we focused exclusively on items of national importance, that where a policy, convening, some type of a best practice around the industry coming together as a public-private partnership could actually help. And so one of the big projects we started about 5 years ago now was the Karen Alliance. And the Karen Alliance is focused exclusively on business-to-consumer data exchange. How do we get more data, health data, personally identifiable health data in the hands of individual patients, members, consumers, individuals at scale? And how do we build on this infrastructure of FHIR APIs that 21st Century Cures initiated, as well as all of the ONC and CMS interoperability rules? And what does a new future start to look like?
And we're actually in a little bit of a new age at this point. We've had new regulations that sort of try and address the whole concept of information blocking. This is certainly my experience. This is a long journey to try and get data out to the patients. Lots of resistance, some for economics, some for other principles, occasionally technical. Tell us a little bit about, the heritage of the Karen Alliance, how it came about, and, what you've done to date.
Yeah. So when we first started, we started talking about this idea that an individual patient could use an app of their choice to then be able to access their health information from any health system in the country. Because we started on the clinical side as a country with 21st Century Cures and some of the ONC policies that were out there. And then we've moved now to the health plan side. But when we did that, Nick, we had these first initial conversations. There were chief privacy officers literally running out of the room. They're just absolutely saying, there is no way, not on my watch. It will never happen. We were in the hallways trying to calm people down, Nick, saying, listen, it's okay. It's been done in other industries. We can do it here. We can protect the data. We're going to do it in a way that is consistent with the privacy best practices of current day, not of HIPAA, 20 plus years ago. But we're going to build on that. We're going to build on HIPAA. We're going to build on CCPA in California, GDPR around the globe. Like, we're going to take, and HIPAA as well, all of those best practices, and we're going to create an ecosystem now that harnesses all of those. And so in that kind of ambiguous kind of start, we kind of now came to this idea of, not only do we have an infrastructure now on the clinical side with EHR vendors that actually support an ability for apps to actually connect access to this information, but as of July 1st, every major payer in the country that's a CMS payer, including all the state Medicaid agencies, are also going to have that same FHIR API infrastructure where apps can come in, they can register, they can get independently certified as an option there. And then the consumer can actually direct their data from any clinical or health plan data source. So now they have a full picture of not only the clinical information about themselves, but also how it affects their pocketbook, what their out-of-pocket costs look like, whether or not their health plan is going to cover their specific treatment protocols. That is certainly transformative, especially when you get into folks with chronic conditions.
So it sounds fantastic from a patient perspective. I think I recognize the experience that you describe with privacy officers sort of bristling at the concept. If you think back to the early days, What were some of the insights or perhaps some of the suggestions or directions that you were able to take to overcome that resistance? Because my sense of it is that still exists. I imagine you can still find folks that would run out of the room hearing some of this. How did you overcome that? What helped in that process?
So it does definitely still exist, Nick, and it's still a big issue, and it's still something that we are tackling. I would not say that we have solved it in any sense of the word, but we've made a lot of good progress. So I think one of the first things we tackled, Nick, is we said, what we're really talking about here is data moving between regulated environments. So data that's moving from the HIPAA regulated environment to the FTC regulated environment, which, oh, by the way, most of your health data is in, let me rephrase that. Most of your data or overall consumer data, whether it's energy data or financial data or other data, is in that FTC regulated environment. Now, basically what the FTC says, and I'm grossly oversimplifying here, is under Section 5A of the FTC Act, it says do no harm to the consumer, and the FTC is going to go and enforce the terms and conditions of the privacy policy and the terms that are in the app itself. So if the app says, I'm going to do nefarious things with your data, as long as they do nefarious things, then the FTC says it's okay. Now,
so if you declare that you're going to do nasty stuff, that's okay?
That's absolutely okay, as long as you state it in your privacy policy terms and conditions.
You mean on page 57,
on
right?
Page 57 that no one reads, Nick, that absolutely nobody reads. That's exactly right. Well, of course, that's never going to work in healthcare, right? There's just no way that that's ever going to work, and nor should it work in healthcare or, frankly, any other industry. Well, the main exception to that is a situation where the industry has come together and agreed on a code of conduct, some type of set of principles or best practices around how that data should be used, managed, and accessed by consumers, and how the app should handle that. So that's what we said we needed to start with. In order for the FTC to ensure that they can enforce this code of conduct, we had to agree on what that code actually is. And so we brought a number of multi-sector stakeholders together. There were over 60 organizations, individuals, patient advocacy organizations, and others that came together and said, let's agree on the set of best practices or principles for how to handle the data. And again, what we did is we took the best of HIPAA, we took the best of CCPA, the best of GDPR, and put them all together and said, here are these set of principles. And what we did is we actually raised the bar, we felt, in terms of privacy and security and consent. And at its core, the Karen Code of Conduct essentially says an individual must consent to the use and data and the sharing of their information across systems. And this third-party app has to act in my best interest. And that third-party app also needs to ensure that any downstream application that uses this data is held to the same standard that the initial app has actually been held to. And what we have found, Nick, which has been phenomenal, and we're humbled by it, is that the industry has adopted this at scale. Health plans are actually using this today. We have a website called myhealthapplication.com that actually lists all the websites that have attested to this code of conduct. We actually even have a certification infrastructure now where there's a group called ENAC that does this certification for HIPAA today that actually Lee and his team has been able to create a certification framework around the code of conduct. So we're starting to build this ecosystem, and it's very nascent stages at this point, of how these apps that are currently not covered by HIPAA should protect the data. And the code of conduct is foundational for that.
So I've got to go back, and I think, foundational sort of incremental point in my mind is, creating that sort of consensus opinion. But I got to ask, how did you get 60 people with highly different views and opinions coming from, provider, patient, you described all of these groups? How did you get them? I'm assuming they've agreed, right? This code of conduct is agreed and everybody's signed up to it.
It is. Well, we certainly started with those 60 plus organizations and individuals, but then we extended it out for public comments. So we got a bunch of public comments on this too, because we wanted the input of everyone in the healthcare community to relate. And we got some great feedback there too. I would say that the process of consensus building is super hard. Leavitt Partners does have a framework for how to do that. Governor Leavitt actually wrote a book called Finding Allies and Building Alliances, which actually really lays out a framework for how he did this in the federal government, and then how we're doing this now. We run about 30 of these alliances a year, Nick, and each one of these alliances are very different. Some are very short term, some are longer term, like Karen. But this process of consensus building has to do with, at its foundation, we have a common pain. And the common pain that each of these individual healthcare entities and organizations felt was, at least at the time, 21st Century Cures requires us to actually create APIs to provide app-based access. So we know that this is coming, and we know that these rules are going to require us to do that. And so what we did is we started with that common pain, and that was a pain felt because they didn't know how they were going to do that. And they recognized that if they could come together and develop a consensus approach for how they wanted to handle that, that would be better than each individual organization trying to do that on their own. And that's really where we started from.
Interesting. So finding the common area of challenge and getting people to coalesce around that file, let's call it, was sort of central. Plus, obviously, the insights to be able to navigate that allowed you. So now you've got consensus, you have a standard, best practices, you've got all of these people. Tell us a little bit about what's happening. You've got, a number of folks signed up. Sounds like we haven't got enough yet. We've got to get more. How's that going? Any experiences from that you can share?
Yeah, so it's been great. So since that initial forming and the forming of the code itself, we've seen that being adopted in production. As part of that process, obviously the ONC interoperability rule came out, and then what happened is the CMS interoperability rule came out, and then so all the payer community said, well, what is this thing about app registration, and what is this thing about moving regulatory environments? So they all started coming. And what does FHIR mean? Like, how do you spell it, right? Like there was all these conversations around that. And so we brought the payer community online with where the provider community was, as well as a whole bunch of other different, what they call HL7 FHIR accelerator programs, where the industry was really driving the standards development process. And so the other things that we've accomplished, we've developed what's called the Karen IG for Blue Button, which is all of your explanation of benefit information, all your claims data that's actually involved at the health plan level. CMS did that back in 2018. We developed an implementation guide, ran it through the standards process with an HL7 and partnered with them. There's now an HL7 STU1 guide to make that happen. That's being implemented at scale all around the country. And so apps can now have a standardized way to access this data through an API based on that implementation guide. We're going to have dental and vision claims in the near future. We're also working on another implementation guide around a digital membership ID card. So just like we do in the physical world now, you provide them your ID card, they get that information, the health plan runs an eligibility check on you, and then they can provide you with additional data. Same thing's going to happen in the digital world now. You can provide a digital representation of your ID card, give it to your provider. That provider then, or that payer can actually then send you back information accordingly. That helps us advance the idea of how do we start to liquidate some of that data exchange when an individual makes that request. And then we're doing a lot of work in the digital identity space too, Nick, which happy to talk about as well.
So before we get to that, let's talk a little bit about the bringing of all of this together. You talk about the standards and the overall sort of requirement to have downstream apps comply with this. One of the pushbacks that I hear frequently is, okay, that's all great, but how is all of that being enforced? Because we know there are bad actors out there, unfortunately, and they tend to muddy the water for many who have good intentions. How are you dealing with that?
Yeah, so to getting a little bit more detailed, at its core is what we call the app registration process. So this is the ability for an app to come to a data source and go through some type of a process associated with ultimately getting what's called a client OAuth secret. And when they get that secret, what that does is it allows them to then use the individual member's username and password that they have actually authenticated with through Smart on FHIR from the app to then authenticate the user in using the app and then being able to get the data out. Well, that app registration process, Nick, right now is certainly manual. There's different ways to do that. We'll be publishing a little bit later this year some best practices on how that actually operates. But what's great about that is that right now there is an ability for apps to self-attest that they're following the Care and Code of Conduct. According to the CMS rule and the ONC rule, any app can connect. But there's going to be some member education around the apps that are adhering to a higher standard versus those that potentially may not be. And even though an individual member can choose any app they want, or they could choose no app at all, they could just actually access the data themselves and say, I want access to this, and here's the form and format that I request. But if they decide to use an app, they can be able to go through that. And then we're working on some technology mechanisms to say, for example, the Karen Alliance or someone else could actually submit some type of a token that says, a jot token that says, hey, look, they've actually signed the code of conduct. We can attest that they've signed it. So digitally, they can know any of these data endpoints to know that they've attested to that. And ultimately, we have the certification framework now too. They can say, look, they've also been certified by a third party. So what that does is it starts to create this ecosystem of trust, right? An app that is formed in a garage potentially would be treated a little bit differently than an app that is connected to CMS and the Veterans Administration and Humana and Cigna and CVS Health and others. That kind of ecosystem of trust starts to be developed because we start to have these core components that can build that out.
So for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Ryan Howells, Principal at Leavitt Partners. We're talking about the Karen Alliance and the innovation, the connectivity that's sort of arisen as a result of bringing this group together under a sort of common pain, as you described it. We were just talking about enforcement and the ability for individuals to come and access this data. As you sort of roll this out, bring other people on, you obviously have to start to scale this, automate it. Trust is an incredibly important thing. How do you maintain that whilst you sort of allow for the broader expansion? What are you thinking about there?
Yeah, so trust and enforcement, let's take those together. I think on the enforcement side, now that the FTC, we have this code of conduct, the FTC can start to enforce that both for apps that have attested, but even for apps that have not attested too. There's some ability to enforce that. In addition, there's private sector enforcement too. And what I mean by that is, this is a small community now, and I'd say small, healthcare is super large, but as far as the folks that are actually involved in coding this out, it's a pretty small community, and these apps are starting to compete based on privacy and security and consent. People think it's nefarious, but most of the folks that are building these apps all have healthcare background, and they're saying, we don't need to get high trust certified, but we're going to go do it anyway. We're going to make sure that the data is super secure because they realize if they lose the trust of the consumer, they don't have a business. And so many of them are running out, getting certified, making sure that they are a trusted endpoint. And so to your point, Nick, how do you build that trust ecosystem out? You're going to see this evolve over time. But I think what you're seeing is that it's still a very small community. We believe there's only roughly 60 apps in production that have actually connected to a FHIR API. So we're not talking tens of thousands, right? And given we now have this this infrastructure that has been starting to build out, we can start to say if there becomes tens of thousands, we can follow a similar approach with all of these apps going forward.
Fantastic. So you teased a little bit, and I think, highly relevant to what's going on around vaccination. But there's this issue of verification of identity. We have some challenges. You talked about a digital ID. It's interesting to me that, we don't have such a thing, or at least not in general use. The current form is, your picture ID, which anybody that has college-age children and knows what the hell they're doing knows that those IDs are not quite as perfect as people think, just to be clear. So tell us a little bit about the digital ID.
Sure. So, other countries, other industries, this is not a new concept, but certainly US healthcare, this is definitely a new concept. And here's the current, idea or paradigm in US healthcare. Number one It's kind of like waiting for Godot, right? We're all waiting for a national patient identifier that's going to solve all our problems, right? That's kind of number one, which is not, whether it happens or not, I'm not here to argue one way or the other, but I would say that's not solving our problem, because that's what's called an identifier, not an identity. And I'll explain the difference here in a second. The second thing is that we treat identity as an organizational level issue, right? Every time I go to a new organization or a new health plan or a new provider, I'm reestablishing my identity with them. And then now I have all these multiple identities and usernames and passwords. I have no idea what they are. Well, we've totally flipped that model around, Nick, and said, you know what? I have my own identity. I'm my own individual. I need to create my digital identity one time. It needs to be trusted, similar to how I do in the physical world today. And then I can be able to use that or federate that across multiple different endpoints. And there's standards out there that allow for this to happen. It's what's called the NIST 863-3 for the nerds out there that want to read some standards related material that, and we're promoting the use. And so is the ONC of an identity assurance level 2, an authenticator assurance level 2. What does all that mean? It means that I, as an individual, can now establish my identity using multiple trusted identifiers that could include my driver's license information, my passport information, all of those things related to it. And all of that kind of makes up my digital identity itself. And then I can start to federate that across systems. So we're building out an infrastructure to make that happen, as well as a federation approach in healthcare.
So, lots of practical challenges, obviously resistance, you're tracking me. I'm sure you've sort of thought about all of those, you're handling all of that. Any thoughts before we sort of run out of time as to how people can think about this to be more accepting that this isn't just another, nefarious project to sort of track? Because I'm sure people are going to go, not everybody thinks this way, but there are certainly some.
Yeah, no, it's a great point. So one, it's got to be equitable, right? Whether you have a government issued ID or you don't, you've got to find a way to make sure everyone's included in this. Number two, you've got to protect the most vulnerable. Absolutely. Number three, it has to be person-centric and person-consented, right? So you're not going to use trackable sources of where you've logged in or how you've logged in. It's an actually identifier, as a digital identity that you control. And it may be established through an identity provider. There are many that are out there. And then the ability for you to be able to use that across multiple systems. But all of that is all consent-based, and you're the one who control that. So it's all part of that ecosystem that we're developing, but it's absolutely privacy first by design.
That's really interesting. I think you sort of hit the majority of the points. And just to be clear, so that everybody understands, all of that's built into the standard.
Right. The NIST standard itself actually outlines the ability for identity proofing individuals. And then the ecosystem that we're developing and the federation environment that we're building will actually promote the use of that privacy by design approach.
So I'm going to go out on a limb here and say there's potential for using this for vaccine concerns, and put to one side whether vaccine mandates are not jumping into that, but just the ability to say this really is the person that received the vaccine. There's some opportunity to sort of tie that all together effectively.
Absolutely. There's an opportunity for that. There's also an opportunity to digitally sign the data so that we can avoid fraud, right? So we're using in that other initiative that we mentioned before, the W3C's verifiable credential standard to digitally sign the data. So I know for certain that the data came from the Mayo Clinic. That is important for a whole set of use cases that we don't have time to get into now, but that we're building out that ecosystem with a number of EHR partners, as well as a number of national pharmacies and others, which will help to be able to build trust in the ecosystem, both B2B and B2C.
Wow, that's really interesting. I can think of one group that's really going to be upset about that. That's college-age students for a whole variety of reasons. Knowing what I know. So, all right. Well, as usual, unfortunately, we've run out of time, but really fantastic progress. I think very exciting. We'll put notes together, including links to the Karen Alliance and, the website that you mentioned, My Health Application. Just remains for me to thank you for joining me. It's been a fascinating conversation. Ryan, thanks for joining me on the show today.
Thanks, Nick. It's been a pleasure.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.